Good evening and warm welcome to everybody. It's a privilege to host this collaborative session between Indian Society of Anesthesiologists and Indian Society of Critical Care Medicine. This joint webinar marks a unique confluence of perioperative care and critical care, bringing together the experts from both the fields who navigate through most complex patient scenarios. And as we delve into today's theme, we aim to foster dialogue, share clinical insights, and enhance our collective understanding to improve patients' outcomes. So let's make this evening an enriching one. I'd like to welcome our ISA President, Dr. Bala Venkat sir, to open this session.
Thank you so much, Dr. Monolisa. And on behalf of the ISA National Headquarters, I request the Honorary Secretary, Dr. Sukhminderjit Singh Bajwa, to share his initial thoughts.
Good evening, sir. President, sir, ISA National, Dr. Bala Venkat, sir. Our immediate past president, Dr. Divetya, sir. And all the senior dignitaries, including our past president of ISCCM, Dr. Sheila Maitra, Bharat Jagasi, my friend, Pandya, sir. I can see on everybody on the screen. Dr. Kajal Jain has just turned our screen. Otherwise, I was going to take her name also. So, welcome everyone. Dr. Anju Garewal is also there. So, regarding this joint webinar, I think it's a step in the right direction going forward in the country where the academics are disintegrated. Societies have come up, new societies, every day new societies are forming. And in our endeavor, we have almost getting successful in taking all the sister subspecialties and super specialties on one platform, especially at ISAC on Raipur. You can see the unity of doctors at IMA, how they're successful, because anything happening in the country, when IMA represents the medical fraternity, they are almost successful in getting the things done. I think similarly, with anesthesia growing at such a fast pace, the society's number is almost touching 50,000, and all the subspecialties and super specialties with other specialties, members of other specialties also coming to these societies. I think joining head together at academic front or at a social front or any front, it is going to create a very good unity. Maybe academics is the best platform to go forward. And this is the beginning of ISA, ICCM webinar, joint webinar. And moreover, we will be dwelling upon very, very important, pertinent topics in these webinars. Not just for the sake of discussion or something like that. Very practical, useful for every member who are going to watch these webinars. So I request Bala Venkat sir to share the vision also of ISA at a larger stage, how we are going forward and how to take these academic endeavors forward, sir. Bala sir.
Thank you so much, Dr. Bajwa. At the outset, on behalf of the National Governing Council of Indian Society of Anesthesiologists, we immensely thank the leadership of Indian Society of Critical Care Medicine for agreeing to collaborate with this joint venture where we will make sure that we get the best out of the both. And knowing the fact that critical care medicine has got several anesthesiologists as a part of it, and also considering the fact that the need for critical care physicians are required more in this country, these webinars are going to open up several vistas of learning, which will be mutually extremely beneficial. And I'm extremely happy that today's webinar was the mastermind of Dr. Divetya sir, who's been a part of the past president of Indian Society of Anesthesiology and Indian Society of Critical Care Medicine. And I'm very, very happy that this new beginning will mark a new journey into learning. And I thank the president of the Indian Society of Critical Care Medicine, Dr. Srinivas Samavedan, who will join us later because he's on the flight. And without wasting time, we will get into the nuances. We have such excellent speakers to talk on two important and pertinent topics today. And I hand over the proceeding back to Dr. Monolisa to take it forward.
Thank you, sir. So today we'll be having two panel discussions. The first panel discussion is difficult airway management in critically ill patients. The session will be moderated by Devatya, sir. Sir has been a professor and head of department at Leelavati Hospitals, Mumbai. He has also been the past president of ISCCM. He has also been the past president of ISA. He is the past editor-in-chief of Indian Journal of Anesthesia. He is the editor-in-chief of IGCCM. He will be joined by a panelist, Dr. Sheila ma'am. He is a professor and head of department of Tata Memorial Hospital, Mumbai. She has been the past president of ISCCM, and she is a chair of ICM Committee of World Federation of Society of Anesthesiologists also. Then we have Dr. Rakesh Garg, sir, who is a professor at AIIMS, New Delhi. He has more than 350 national and international publications and many book chapters. And he's also the editor-in-chief of Indian Journal of Anesthesia and Journal of Onco-Anesthesiology. We have Dr. Bharat Jigyasi, who is the clinical director of Kokilaben Hospital, Navi Mumbai. He has been the general secretary ICCM last year. And we have Dr. Saeed Moeed with us, who has been the editor-in-chief of Central Journal of ISA, in charge of ICU in Jawaharlal Nehru Medical College, Aligarh Muslim University. So without any delay, we'll start the first session. Over to you, sir.
Sir, you are muted, Divetya sir.
Thank you, Dr. Mona Lisa, and thanks to the leadership of Dr. Bala Venkat of ISA and Dr. Srinivas of ISCCM for getting the two societies together to collaborate in this academic endeavor. So I think we'll rush straight into the topic. This will be a panel on airway management in the critically ill patient in the ICU. And our panelists for this will be Dr. Sheila, Dr. Moeed, Saeed Moeed, Dr. Rakesh Garg, and Dr. Bharat Jigyasi. So, airway management is crucial to both specialties. Anesthesia is the bread and butter, and so is it for critical care. So my question is, what is different between airway management in the critically ill patient and what the anesthesiologists do in the operation theatre? Anyone wants to take it? Dr. Rakesh, would you want to take that?
Right, sir. So when we talk about the operating room airway management, it is quite focused most of the times. We have the time to assess the airway, and usually we use the terminology called anatomical concerns of airway management. But when we move to the critical care management, the patient profile is altogether different. At times, it could be more of an emergency or a semi-emergency or urgency nature. And in addition to the planned anatomical airway management, we also have certain concerns about the physiological aspect of the patient, because this patient profile is altogether different. So it's not just the anatomy of the airway, but the impact of airway management on other aspects, which we labeled as physiological aspects of the difficult airway or airway management, is another concern. And at many places, the concerns of the equipment, the human factors, and the availability of call for help also remains a concern. So these are broad headings under which we can say that airway management is probably altogether a different ball game at two different places. And that's why we need to be well prepared, have structured strategy for management of airway. We need to have expertise in form of manpower and the equipment, a cart, which is should be available at these places so that we can manage them effectively.
Yeah, so thanks, Dr. Rakesh. So essentially the patient is different, the environment or the setting is different, and maybe even the expertise of the operator is very different. So in the OT, you got trained anesthesiologists supervising, but unfortunately in the ICU at about 2 a.m, the sickest patient in the hospital is being intubated by the most junior and inexperienced doctor in the intensive care unit with almost no help, with minimal sort of the paraphernalia that we have in the OT is just may not necessarily be available. So given this setting, that the patients are sick, the doctors may not be very good. Dr. Moeed, is there any documentation that it is more dangerous for patients, or, how dangerous is it? What is the incidence? Is there an incidence of complications, say, compared to the OT intubations when we handle the airway in sick patients in the ICU?
Yeah, if you see the NAP4 study, and the report of it, when Tim Cook came up with the alarming result, finding of that, it's around 60% of the people of ICU patients in comparison to only 14% in anesthesia. They're really they have a lot of complications, and out of which, if you see that around 38 mortalities occur in comparison to only 14 in intensive, I mean in an anesthesia or operation theater. So naturally, you see the incidence is pretty high. It's around 60% and 14%. So naturally, these people are critically, as we have already discussed, that the physiological reserve is less. They desaturate very fast. They're hypotensive at time and hypoxemic, so naturally they collapse very fast. And at the same time, they have a lot of complications in the form of aspiration, cardiac arrest, and this goes on fourfolds if you don't have a very good, especially the expertise, the equipment, and the, as we said that environment. So time is also a very crucial factor in these patients. We don't have time to analyze this or assess these patients appropriately. So incidents are pretty high when we talk about intensive care unit. It's around 60%. So it is documented.
So the incidence of complications, especially hypoxemia and hypotension, seems to be quite high in sick patients in the ICU. Yes. So Dr. Sheila, you have you've propagated this concept of the physiologically difficult airway. Can you elaborate a bit more on this and the complications that you have? You've led some international multi-center studies on complications in the ICU during intubation. So can you just elaborate a little more on the concepts that Dr. Rakesh and Dr. Moeed have thrown up so far?
Right. Thank you so much. At the outset, I'd like to thank the Indian Society of Anesthesiologists for giving me this opportunity to represent ISC on this panel. Going straight to your question, sir, the first thing is the incidence over the time has been between 40 to 60%. The NAPFO was about 10 years old, but more recently, the Intube study, which was we published in JAMA, was a real-world study giving data from low and high-income countries, and it showed an incidence about 45%. Perhaps over time, the complications have come down, but the most common complication is hypotension and not hypoxia, as we imagined. So perhaps over time, we're becoming a little better at our peri-intubation oxygenation, and the incidence of hypoxia is only about 9%, and hypotension remains 42%. The entity physiologically difficult airway has not been coined by us. We have a recent consensus definition. This was first described by John Sackles, who is an ED physician, in 2015. And he talked about this concept of physiologically difficult airway, where, physiological changes in the patient resulted in increased pathological and physiological changes, alterations in critically ill patients resulted in complications. But the physiologically difficult airway is not limited to critically ill patients. Essentially, it is any condition in which physiological and pathophysiological alterations increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. So it could be a critically ill patient, it could be an obstetric patient, it could be a pediatric patient, anyone who has a low reserve and physiological alterations. So recently, through a consensus Delphi, which we published in Intensive Care Medicine in 2024, we redefined this and broadened the definition of physiologically difficult airway. Of course, today we are talking about in the context of critically ill patients. So in critically ill patients, the physiological alterations such as hypotension, hypoxia, right ventricular dysfunction, metabolic acidosis, raised ICP, all these increase the risk of complications during tracheal intubation. And that is what we mean by a physiologically difficult airway. As an anesthesiologist, and as Dr. Rakesh rightly said, we've always focused on anatomically difficult airway. All our scores are related to anatomical difficulty. And, we've never thought of this entity, that it's not a new entity, it's just been recognized more recently, that these changes can actually result in such high complications. And as Dr. Moeed said, there is a stark difference in the complications that occur in the operating room and in the intensive care unit. And as an anesthesiologist coming from, the operating room, when I stepped into the intensive care unit, and I used to wonder that why is it that in the same period of time, the complications are so high in the operating intensive care unit as compared to the operating room. And as you rightly said, it's the environment, it's the experience of the operator, and most importantly, the patient and the physiologically difficult airway that increases the risk of complications.
Okay, great. So thanks, Dr. Sheila. So, a lot of these complications, the when the patient has got pneumonia, he's sick, he's hypoxic, and then the reserve is reduced, and we commonly do we paralyze the patient, we give a relaxant, and then we intubate the patient. And in that time, with such a low reserve, the time available for intubation is very short. And if you take time or if you make some struggle a bit, then the patient desaturates very fast. And so I think essentially, most of us practice what we call as rapid sequence intubation, right? So Dr. Bharat, just to expand, to take this discussion forward, can you just briefly tell us how you do or how we do a rapid sequence intubation in the ICU?
So, sir, thank you for that question. So, basically, as you rightly said, in the anesthesia, in the OT, we have the time. Our patients are nil by mouth for a period of time, and in the ICU, it's an emergency thing. So, we do it to prevent the aspirations and aspiration and achieve. We have to achieve rapid unconsciousness paralysis. So, and it's very important as the time is very less to do this. So initially, of course, will be the preparation. We have to assess and resuscitate and gather the team. So we have to have the gadgets ready, like suction, airway. We have to pre-oxygenate the patient. It might not be possible in many of the situations in the ICU because sometimes the patient collapses suddenly, and the best way is to achieve the airway as quickly as possible. If we have the time, maybe around 5 to 10 minutes as well, and pre-oxygenate, learn the sympathetic response. And of course, the positioning of the patient is also very important. We have to achieve the sniff and ram position, whichever is possible, especially in the obese patient and hypoxic. And then how do we do it? We have to choose the right induction agents as well. So basically, when we talk of initially the etomidate was the preferred agent in the ICU, but now we have recently seen the mortality is gone with the etomidate because most of the patients are the septic patient, and we have the recent meta-analysis also which said the mortality goes up. So so we have to prepare the patient, apply the required pressure, and attempt the intubation as quickly as possible. And so of course this is how we do it, sir.
Okay, so you give some induction agent to put the patient to sleep. Before that, you pre-oxygenate.
We pre-oxygenate the patient if the time is available. We avoid the relaxants in such patients because we don't want the reflexes to go away. And when the induction agent is preferred, so etomidate is not practiced these days because most of the patients are septic patients. So we combine the ketamine along with the propofol. That is the agent of the choice. If at all it's a difficult intubation, we have to choose the induction agent in these cases. And if the mouth opening is partial or it's not practiced in a way, then we might consider using rocuronium, but it needs to be very dangerous. The patient is NPO. The enough required patient needs to be applied, and the required patient itself becomes a problem in many of the cases because it might obliterate the view of the operator, or in some cases, if it's a more of a required pressure, then of course it obliterates the vocal cord as well. So eventually the crash card, if I have to make a flow chart, crash card needs to be ready. Patient needs to be pre-oxygenated. Give the induction agent minimalistic as is required, avoid relaxant agents, and second operator applies the pressure minimal to prevent the aspiration and intubate accordingly.
Okay. Dr. Mohit, do you do your intubation in the ICU any differently?
Yeah, it's a bit different because I would always prefer to give, first of all, my pre-oxygenation is a bit different because already the patient must have been already on an NIV. So I would continue that NIV, and at the time of intubation, I'd like to go with and switch over to high flow nasal oxygenation or oxygenation around 15 liters per minute. So just to buy some time, we have an apneic period which will be increased. Further, if the patient is already on an NIV, naturally, if you take a bag mask ventilation, is not going to be sufficient because the patient can desaturate. So naturally, saturation has to be maintained, one very important thing. And pre-oxygenation should be always in the form of what he was already receiving. So maintain it. And when you are intubating this patient, when the patient is apneic, so better to go for high flow. This is one thing. Secondly, I would always prefer some amount of relaxants in these patients because we've seen that relaxants primarily it fastens your intubation. It eases your intubation. So naturally, I would like to go for either succinylcholine or rocuronium, whichever is feasible. And I'd like to give some amount of induction in this patient, especially in the form of ketamine. And of course, etomidate is still a query. But if the patient is not a sick patient, if the patient is just otherwise, then naturally etomidate could be a choice. Ketamine with a propofol combination is also coming up as now in the form of ketofol, but I would always like to go with ketamine in these patients. And cricoid pressure, of course, at the time, because these patients are already expected to be a full stomach patient. So naturally, cricoid pressure needs to be maintained at the time of intubation, at the time of bag mask ventilation with a pressure of around 5 to 15 centimeters CPAP, along with, say, 5 centimeter P. So I can give a modified, bag mask ventilation or rapid sequence intubation, what you will say. And then we need to intubate with a video laryngoscope, which would be my best choice in these patients, so as to help me to intubate.
So Mohit, you're going to go with a pre-oxygenation induction with ketamine and a relaxant.
Yeah.
Dr. Rakesh?
I think ketamine is emerging one, so this will be one of the agent. But simultaneously, apart from these drugs, because sometimes when these patients are with sepsis, I would also make them connected with some vasopressor agent, because whatever drug, whether it's ketamine or etomidate, they will have some fall in the pressures. So vasopressors are already pre-connected so that during the peri-airway management, in case required, we can increase it on. And important point nowadays, as Dr. Moy said, many patients are NIV. But now HFNC has entered into the ICU very nicely, and it is a bridge somewhere between NIV and intubation. So sometimes the patient will be on HFNC when we take a decision to intubate them. So in case if it is being used, it needs to be continued so that oxygenation continues, and then we can go ahead and use ketamine propofol combination. But also the choice of drugs will depend upon certain specific situations also. At time like patient who are myasthenia gravis patient or neuromuscular disease, they are different cohort of population. Sepsis patient is one cohort of population. And sometimes there will be other, like say, trauma patient, bleeding patients, post-operative patients who are bleeding excessively. So these are different cohort of populations wherein some difference in the management with regards to the choice of drugs would also be considered.
Okay. So now, Dr. Sheila, you've been a part of many consensus meetings and many expert groups. So what is your view on with relaxant and without relaxant, and which drugs you use to induce the patient, right? Just to sedate the patient, whether you use, say, midazolam fentanyl or propofol or ketamine or etomidate or a combination, just this aspect, this
Right.
initial.
Yeah, thank you so much for this is a very, very important point. And I see a lot of physician intensivists avoiding muscle relaxant. And I want to make a point very emphatically, a rapid sequence intubation, you must use a muscle relaxant, especially if you are less experienced airway operator. It not only increases your chance of a better mask ventilation, as well as increases your chance of first pass intubation success, and has been clearly demonstrated to reduce all the complications known to be associated with difficult airway. So whether you use rocuronium and or succinylcholine, you could use either, depending upon the of course, as Rakesh said, it's depending upon the type of patient. You may have to avoid scoline in some patients, but we must give a muscle relaxant. Coming to the induction agent, now the verdict is not out there whether ketamine is superior to etomidate, and there were always also concerns about adrenal insufficiency and problems with etomidate, but that's not really been established. And there are 3 recent meta-analyses, and they have not really demonstrated. There's a slightly reduced mortality with ketamine, but not statistically significant in the meta-analysis from Yuki Kotani. So for us, it's very good because ketamine is very cheap. So you could use either, unless contraindicated, should be the drugs. Now, as an anesthesiologist, I love propofol. I use propofol for induction in the operating room, and propofol blunts your airway reflexes beautifully. Ketamine is a drug we've thrown out of the operating room many years ago. So it's a natural tendency for anesthesiologists to use propofol in the intensive care unit because we are so familiar with the drug, and we also shoot it very rapidly when we give the drug. But when in the INTUBE study, which had an incidence of 42% of hypotension, we went back and did another study, and we looked at all those patients who had hypotension, 42% patients, and we did a multivariate analysis, and propofol was the independent modifiable risk factor associated with hypotension. And the really important message from this study, which we published in the Blue Journal, is that irrespective of the starting blood pressure, propofol independently transitioned to hypotension. And this is a very important message because I remember if the blood pressure was fine, I would use propofol. If the blood pressure was low, I would use ketamine or etomidate. So the message is that irrespective of the starting blood pressure, you should use either ketamine or etomidate for your induction, because these patients are very prone to hypotension. One more point I want to make. I see a lot of units where people use a bit of midazolam, a bit of fentanyl. They avoid using induction agents, then they don't use relaxant, and it becomes a very, difficult intubation actually. And it's for fear of the intubation not being difficult that the induction agent is avoided and the muscle relaxant is avoided. So I think as airway experts, we need to emphasize this point, that give a muscle relaxant and give those induction agents, and don't just give a bit of fentanyl and a bit of metronidazole. Thank you.
Okay, so great. So, yeah, so I think Dr. Sheila has put it in a nutshell that use ketamine, maybe etomidate, use a muscle relaxant, and there is probably a legitimate fear that, if you give a relaxant and you can't intubate and you can't ventilate, you might land up in trouble. But it needs a little bit of training, a little bit of experience, and I think giving a relaxant makes complications actually lower. That has been seen. So I think 2 points have come up. One was hypoxia. Dr. Mohit was focused on preventing hypoxia, and Dr. Sheila was focused on hypotension, right? In my previous life, when I was in Tata Memorial Hospital, 15 years ago, even before we thought of the Intube study or anything, propofol was banned in the ICU for intubation. So this is a well-known, a good way to increase your noradrenaline usage by using propofol in the ICU. So I think we would sort of stay away from propofol in the ICU. So Dr. Mohit now spoke about preventing hypoxemia. Can you just tell us what are the important steps throughout the intubation process that you will take to reduce the incidence or severity of hypoxia when you're intubating a critically ill patient?
So first of all, naturally, as I said, that it's always advisable to maintain the same, pressure and what he was receiving. The patient was already on NIV. Try to make the patient let the patient be on NIV, and at the same time, when you're switching over from when you're making the patient apneic, it is better to switch over to high flow nasal oxygen condition. So high flow oxygenation is better, because then you'll be at least being able to oxygenate this patient, and because that ventilative mass flow is there, so naturally patient will have a continuous oxygenation. This is something which is very important at the time of intubation. The patient is relaxed and you're doing a laryngoscopy. So this has to be maintained so as to prevent desaturation. The second point is that you can go with some amount of backmask ventilation with a PEEP of 5 and a CPAP of say 5 to 10 centimeter, 15 centimeter water, with a very gentle backmask ventilation before you are trying to intubate this patient. So this is one thing. And in between, supposing you're having number of attempts, so in between also you can go with a backmask ventilation with this technique, in this situation as well. And naturally, the other point is keeping the patient's bit propped up around 20 centimeter, 20 degree up. That also will prevent will help you to decrease the desaturation to a certain extent. So these three points I would always try to emphasize. And of course, because we know that hypotension is all associated with hypoxemia, so I would always like to give some amount of fluid to this patient before I start with this, because that is again a component which will be there if a patient is having hypotension. So hypoxemia can also prevent hypotension can also prevent some amount of hypoxemia as well.
So for hypoxia, basically what you're saying is you should give NIV,
yes,
invasive ventilation, when the patient is breathing, and then once you've paralyzed the patient, you will make sure that there's apneic oxygenation with high flow nasal oxygen.
Yes,
and
yes,
that's so. Dr. Rakesh, if the patient is on a high flow oxygen mask, the non-rebreather mask, should you and conventionally we always use a ambu bag and mask for pre-oxygenation. So is there if the patient is not previously on NIV, right, or he's just on some oxygen therapy, is there an advantage of giving this person NIV purely just for the sake of pre-oxygenation, So in other words, is NIV has an advantage over bag mask, or rebreathe of a mask and ambu bag, or should you, or is HFNC, should we switch to HFNC, or so what should you do? In other words, bag and mask pre-oxygenation and HFNC for pre-oxygenation or NIV for pre-oxygenation, which is the most superior of?
It definitely will depend upon the individual patient assessment. If you see the recent data which are coming up, the NIV based pre-oxygenation is almost comparable to the HFNC at 60 to 70 liters. So they have a role. We cannot compare them with non-rebreathing masks which are at low flows. But if somebody do not have the options of HFNC available, then they can given a combination of some amount of NIP with the nasal prongs add-on, which will give a higher flows. But if you see the recent data which are coming for the last couple of months to years, HFNC is finding a good role because during the intubation process, the airway management process, the high flow oxygenation continues, number one. Number two, HFNC also has some beneficial effect of some component of CPAP being provided. So when we say these critically ill patients, when they have some risk of airway collapse and obstruction, that will be taken care of. And it will be an unhindered path for the oral airway management if we are using this one. So basically it depends upon patient-to-patient profile. If we have a high risk of patients, they are ARDS patients, probably they will be requiring some support if NIV and needs to be continued during the airway management.
Yeah. So I think NIV is good because you can give a definite amount of PEEP. The amount of PEEP with high flow nasal is variable, and it depends on whether the mouth is open and all those kind of things. And I think maximum you can get is about 3 to 5 CPAP with NIV. So I think there was a very nice review in intensive care medicine. Probably Sheila was one of the authors on that. If you got a sick patient, then NIV is probably superior to HFNC. But if he's not very hypoxic to start with, then HFNC is not a bad option, starting from pre-oxygenation down to apneic oxygenation and so on. And one study, a small study, also given HFNC along with NIV for pre-oxygenation, and that was found to be better than either of the two components individually. Okay.
So I have a point to make.
May I add? Yeah, sorry.
Ma'am, you go ahead, please.
No, I just wanted to add to the pre-oxygenation part. So there's very recently in Lancet Respiratory Medicine, a meta-analysis published of comparing all the techniques, high flow nasal oxygen, NIV, combination of high flow nasal oxygen, NIV, as well as conventional oxygen therapy that we're talking about. And they have clearly found that, as Dr. Mohit and Dr. Rakesh said, that high flow nasal oxygen and NIV are far superior to conventional oxygen therapy. Because of the delivery of PEEP, which is required in this high risk of patients. But they have also found that among the two, in the high risk of patients with moderate to severe hypoxia, with PaO to FiO2 ratio less than 200, NIV is more superior, probably because of more definitive delivery of PEEP in these patients. So in the more severely hypoxic patients, we should consider NIV, and probably it's time in the critically ill community to completely abandon the use of the conventional oxygen therapy unless you don't have these modality, and we should think of more superior forms of oxygenation. And just one more point, I see Kajal Jain is all over here. One other technique that we talked about rapid sequence intubation, but we should also talk about delayed sequence intubation. Now, delayed sequence intubation is not a very familiar term in the intensive care community. It's used a lot in the emergency department. This was first described by Scott Weingart from the United States. And what they did is that a lot of these patients who come for emergent intubations, they're very hypoxic, they're very rowdy, and they don't allow pre-oxygenation. So these are the patients who need pre-oxygenation the most, but we are unable to pre-oxygenate them because they don't allow it. So what we tend to do is just rapidly induce them and intubate them. And we don't give enough time for pre-oxygenation. So the delayed sequence intubation is a technique by which you can give ketamine in low doses, like small sleep doses, about 1 milligram per kg. And the patient becomes very calm. Obviously, you know how it is when you give ketamine. And then you can pre-oxygenate them well. And it's really interesting because I've started using this technique a lot in the intensive care unit. And some of these patients who come and you look at them and you think, I want to intubate him right now. Some of them, after some time, you think that, oh my God, they really actually don't need intubation. And even if you want to do an awake intubation, you can proceed for that. Or then after that, you can proceed for RSI after giving a good amount of pre-oxygenation. And I'm really proud that Kajal is here. The first randomized controlled trial that tested delayed sequence intubation versus conventional RSI was led by Kajal and comes from PGI Chandigarh and was published in Anesthesia and Analgesia, which actually showed that oxygenation at all time points was superior when delayed sequence intubation was used with the RSI. So I just wanted to emphasize this aspect of pre-oxygenation and the importance also of peri-intubation oxygenation, that's nasal oxygenation during attempts at tracheal intubation, which is very important. Thank you.
Yeah, Bharat, you want to make a point?
Yeah, sir, I just wanted to say we need to be very sure and see what is the reason for patient is getting intubated for. If hypoxia is the reason, then these are valid point to discuss. Of course, that patient would be on a moderate to severe hypoxia, ARDS or hypoxia. This patient would be on the NIV, and in that case, it makes sense to use the NIV instead of the bag mask ventilation. But if the reasons are different, just to protection of the airway, that the bag mask would do is not sensible to open the whole NIV set. Now, NIV versus HFNC, so it's apneic versus non-apneic ventilation. So someone who's breathing, then of course NIV is better. But if we need an apneic oxygenation in certain cases where we don't know the patient's NPO status, or maybe the patient has been operated for the GI surgery recently and there is a relative contraindication. So there's the area where we have to consider HFNC, because when you pass on the message saying HFNC versus NIV versus, then it might happen. So they will open up the whole new set for the cases where it's actually not required.
I think that's a reasonable comment. So this is, when we are talking of hypoxic patients whom we are intubating for acute hypoxic respiratory failure. But yes, if you're intubating someone, if you're Guillain-Barré or one of the neuromuscular conditions of just for airway protection after head injury or something, then maybe you can do with simple stuff. But if you're dealing with someone who's hypoxic, who's aspirated, who's got a pneumonia or ARDS or pulmonary edema, whatever, I think you need to keep in mind that you need to use either NIV or HFNC, which is superior to simple bag mask oxygenation. So that's a good point, and we do have to consider costs in our setup. So that's a reasonable point to make. Okay, so I just want to ask you.
If I may just add one point, there's no question of opening a set. We are intubating the patient. We already have the ventilator and we have the circuit.
Yeah, some people have
when we're talking about NIV, we mean pressure support and PEEP that is delivered through the ventilator using a mask.
No, mask and the HFNC set is different. NIV mask is different.
Okay.
So they have separate ventilators and circuits for NIV, I guess. So that's why that point has come up.
Circuit remains the same, extra mask we need to open, sir. And the HFNC is a different set altogether.
So I just want to ask quickly, each one of you just say yes or no. Which is your laryngoscope do you use for intubation? Standard laryngoscope or a video laryngoscope? Bharat?
So we
the usual thing.
Have both, but preferred is video laryngoscope, but there are certain set of doctors who are not per se, and they use the standard laryngoscope as well. The preferred is video laryngoscope. Sorry,
Rakesh?
sir?
The preferred is video laryngoscope, sir.
Mohit?
I'm always using video laryngoscopes. Always.
Yeah, video laryngoscope. We've completely changed to video laryngoscopes.
So I think video laryngoscopy is now being advocated. Unfortunately, many people are not familiar with video laryngoscopes, and they tend to use direct laryngoscopes. But I think we've got very good evidence from a recent trial, that video laryngoscopy is superior too. So I think as far as possible, people should get trained in video laryngoscopy and start using video laryngoscopy for intubations. Last couple of quick questions. So we all talked about hypotension, right? So Dr. Sheila, very quickly, why do you get hypotension after intubation? You mentioned that even a normotensive patient sometimes crashes after intubation. Why do you get, and what are the strategies can we prevent it?
Yeah, they're a very good question. So we've already, first, most importantly, is the critical illness itself. Many of these patients are in septic shock. They already come hypotensive. Then we've already talked about the effect of drugs, right? Like propofol, midazolam, opioids, etc. But another important reason for this hypotension is, the positive pressure ventilation that we give. The hypotension occurs immediately after intubation. So these patients are already hypovolemic. And after you intubate them and you give the positive pressure ventilation, there's, the increased thoracic, intrathoracic pressure, decreased venous pressure, return, and decrease in cardiac output, and you have fall in blood pressure. And the other very important thing is that, especially these patients who come to the intensive care unit in acute hypoxic respiratory failure, they have a very high sympathetic drive. So you will see the tachycardia, hypotension, and this keeps their blood pressure up. And this gives you a false sense of security because you think this patient's blood pressure is okay. And these patients are hypovolemic, and it's the sympathetic drive that's keeping their hemodynamics fine. And as soon as you give them propofol, they have precipitous fall in blood pressure. And this is what you have to be really careful about. This doesn't really happen in the operating room because you don't see these patients coming like this, hypoxic. So these are the most common causes of hypotension. We've already talked about what drugs to use and, of course, gentle ventilation after intubation. But the important thing is that the incidence of hypotension is 42%.
Prevention quickly.
So, people have tried fluid boluses. That was part of the intubation bundle. But 2 randomized controlled trials, the Prepare 1 and Prepare 2, have shown no difference whether you give a fluid bolus or you don't give a fluid bolus prior to intubation in these patients. Of course, there were a lot of limitations in this trial, and we can't discuss this. So hypotension is real. A fluid bolus doesn't seem to be making a difference. So perhaps there is a role of giving a low-dose vasopressor before intubation, given peripherally, of course, through an IV line to prevent rather than just to treat this hypotension. And there are 2 trials underway. One has just been completed at the Tata Memorial Hospital, which is called the FLUA trial, where we are comparing, I'm still not convinced that fluid boluses don't help. So we are comparing fluid bolus with 500 ml of saline versus a low dose of vasopressor, and this is norepinephrine, 0.08 microgram per kg per minute, given peripherally 10 minutes prior to intubation. And the other trial is the prevention trial, which is being done by the European Society of Intensive Care Medicine. I'm on the steering committee of this, where they are using usual care in one arm and low-dose vasopressor on the other arm to prevent prior to tracheal intubation. So the results of these 2 trials will actually give us a very important answer to the question whether use of a low dose of vasopressor to prevent hypotension actually reduces the incidence of cardiovascular collapse following tracheal intubation.
Great, thanks. Now, quickly, just Dr. Mona Lisa, 2 minutes more.
Yes, sir.
Okay. So, Bharat, we've talked about general intubation. Now, I'm giving you a very specific scenario and just a very, very quick answer. You have a patient in cardiogenic shock. Okay. Hypotensive, shock, bad heart, myocardial infarction, pulmonary edema, needs intubation. Do you do anything different in this sort of patient? As far as
usually, if the patient is straight away come in, so nothing different. We just go ahead and intubate this patient. If the patient is on NIV, then of course I have a time because I've just the NIV. Then I'll pre-oxygenate the patient for a while, prepare, and then do it. If it's an emergency situation, then straight away, sir, as you suggested, RSI, we go ahead and intubate this patient. And of course, if the hypotension is there, then everything goes simultaneously. We start with the vasopressors and continue while the intubation is being prepared.
Okay. Mohit, Dr. Mohit?
Yes, sir.
Patient with head injury.
Yeah.
Do you do anything different? What drugs do you use? What technique do you use? How do you do it quickly?
Only thing is, naturally, in these patients, we have to keep in mind that these are trauma patients. So naturally, full stomach is 1 point. So naturally, that's same thing, whatever is being done.
Is there a risk of, you mentioned that you can give gentle positive pressure in your this thing. Is there a risk of aspiration when you do that? Or it's not a big deal?
There's always a risk, sir. For that, naturally, we maintain that cricoid pressure while we are doing this. But at the same time, we try to weigh which is more important, whether hypoxia is more important or aspiration is more important. So naturally, after giving a prokinetics or the antiemetics, we always would like to go for a bag mass ventilation. One thing very important is we need to avoid certain drugs in these patients because we need to think about the intracranial pressure, right? So naturally, ketamine is again one problem when we use this drug. Probably at this point of time, propofol could be a better choice in these cases. So this is what is primarily we need to think when we talk about head injury patients.
Okay, fine. So ketamine is actually making a comeback even in head injury because it maintains the CPP by keeping the blood pressure up, whereas propofol, again, if it drops the blood pressure too much, that could be a little more dangerous. So again, ketamine is slowly clawing back into critical care and so on. Okay, so I think we don't have time to go into difficult airway. We'll stop here. We just know that, just remember that even the normal looking airway is a difficult airway in a critical patient because of the physiological issues. So I think we'll stop here. I thank all the panelists for their lucid comments. And do we take questions now?
Yes, so we can take 1 or 2 questions and then we'll move to the next session because most of the questions are already covered by the panelists in the discussion. I thank Devatya sir for having this excellent discussion, very practical points covered. So one question, sir, Dr. Arjia asked that if we have a predicted difficult intubation like an intraoral tumor and we fell into an emergency hypoxic situation, so what will be our preparation and how do you secure the airway following the guidelines?
I think either Dr. Sheila or maybe Dr. Rakesh can take this one.
Sir, I think it's already predicted difficult airway, so anatomical and physiological both aspects. So when we say anatomical difficult airway, the awake intubation is the priority here. And for this, we have to topicalize the airway and the oxygenation will continue and then secure the airway while the patient is awake. So this remains the standard therapy. And subsequently, once the patient airway is secured, we can think of other drugs if required for tolerating the tube for this patient, depending upon the requirement. So this is the standard management we need to follow for this. And with regards to the awake airway management, usually the video endoscope or fiber optic scope remains the standard of therapy for these patients, but adequate topicalization is essential, which has various techniques, either using regional block, which may not be feasible in certain situations of the head and neck cancers, but spray as you go remains the other technique which can be used for these patients for topicalization and allowing the awake airway management. But remember that the strategy for oxygenation must continue, preferably using HFNC for these patients during the awake airway management.
So one thing, can I add?
Quickly.
Yeah, we can nowadays we have this hybrid technique as well, because since this is an oral tumor, but the problem
more difficult techniques. So let's not get into hybrid technique.
So if I may add, so an awake intubation is good if you have the time and the patient is cooperative. But 90% of the time, if it's critically ill patient and it's an emergent intubation, this can be a very challenging intubation. Doing any kind of topicalization is not going to be feasible, neither any blocks. So you really have to spray as you go. One of the drugs that you can use to facilitate it, again, is to give a little bit of ketamine and then go ahead doing a flexible bronchoscopy. Otherwise, whatever you do, when you know it's an anticipated difficult airway, you should be absolutely ready to do an emergency cricothyrotomy. You have to have a double setup. You cannot go ahead with this case without thinking about doing a neck rescue or an emergency cricothyrotomy right up front, because this can lead to a very dangerous situation if you lose the airway. And even putting in a supraglottic airway device with an intraoral tumor is going to cause bleeding and is going to be difficult. So you have to bypass a lot of steps in the algorithm, and you may have to directly proceed to emergency cricothyrotomy.
I was going to say that in this particular question, you have to consider an elective tracheostomy.
You may have to consider that. Yeah.
So I think we'll wind up here. I think Dr. Mona Lisa is getting impatient. Sorry to keep you waiting. There's another panel to follow. Dr. Kajal had to some point, but I guess she can make it during her panel. So thank you.
So we have some more questions. I think we can answer it while the other session is going on. And if there is time left, we can take it after the second session. So we'll start with the second session. I would like to thank all our panelists and moderator, Dr. Devatia sir, to join for the first session. So the second session will be on obstetric anesthesia and critical care. It's a very important topic. The session will be moderated by Dr. Sharmili Sinha ma'am. She is the senior consultant and critical care in Apollo Multispeciality Hospitals, Bhubaneswar. She is the general secretary elect this year, and she has also been the vice president and EC member of ISCCM. She is joined by Dr. Kajal Agarwal ma'am, who is working as a head of anesthesia and critical care at PGI Chandigarh, and Dr. Ranajit Chatterjee sir, who is working as a head of critical care in Swami Dayanand Hospital. Then Anju Grewal ma'am, who will be joining us. She is working as a professor and head in Department of Anesthesiology in AIIMS Bhatinda. And Dr. Sunil Pandya sir. I welcome you all, and we'll open the session. So I'll request all the attendees to keep posting their questions in the chat box, and we'll try to answer them as soon as possible. And we'll start. Over to you, ma'am.
Thank you, Dr. Mona Lisa, for your kind words of introductions. And it is indeed a privilege to moderate this session on obstetric critical care. It's been, we just witnessed a very engaging discussion on the difficult airway. And I'm glad to see already questions showering in the chat box and queries regarding obstetric critical care in the box. So we'll proceed with a case scenario, and we managed to get a case scenario which will actually encompass and include all kind of possible or challenges related to critical care. So please allow me to share my screen.
We can see your screen, ma'am.
Yeah. So let's proceed. So this is a case which we have really treated slightly modified in view of to conceal the privacy. She's a 35-year-old lady who is obese, and she had a failed IVF but spontaneously had a conception. She was undergoing regular antenatal checkups, and there was no medical comorbid conditions till that date of emergency arose. At 36 weeks, she had water leak. She was staying close to a small nursing home, and she was taken up to that nursing home where emergency cesarean section was performed under spinal anesthesia. And towards the end of the cesarean section, she suddenly developed postpartum hemorrhage. Pack and tamponade was given for that matter. And the obstetrician tried to close. And at the same time, just after minutes, she suddenly developed respiratory distress with tachycardia going up to 150 per minute, sinus, and she became drowsy, requiring 1 or 2 liters of oxygen. The anesthetist present there immediately intubated and ventilated because she had started dropping her saturations, and blood pressure was also on the lower side. So at this juncture, I would like to know from Dr. Sunil Pandya, sir, so what are your differential diagnoses for such a condition?
Thank you, Dr. Sharmili, and thank you, IS and ISCCM, for this wonderful combined webinar. So coming straight to the case, I would say that whenever we have a patient who has the similar presentation, we have developed an algorithm in our practice, and we have a task force guidelines of AOA also, where we go by the acronym ABCDUPS. Like we just follow this algorithm. A is for anaphylaxis and anesthetic causes, B is bleeding, C is cardiogenic causes, D is for drugs or medication errors, E is eclampsia or hypertensive or embolism, and U is uterine causes, P is pulmonary embolism, and S is sepsis. So if we follow this algorithm, more or less all the cases of this peripartum collapse can be diagnosed. So in this case, this patient has developed pulmonary edema or respiratory distress towards the end of cesarean section. So unlikely that it is anaphylaxis, unlikely that this is anesthetic cause, and because the history of water leak is there, most likely she may be having a premature rupture of membrane with chorioamnionitis. And during surgery, the sepsis has flared up and it has become a systemic sepsis causing acute lung injury or ARDS type of presentation. But background, as I said, cardiac cause also cannot be ruled out because at least 25 to 30% of cardiogenic disorders in pregnancy, they present immediately postpartum. So we just have to linchpin the diagnosis, differential diagnosis. One is either sepsis, septic shock, or cardiogenic related issue, and we need to work this up. So while you are putting your differential diagnosis, you also need to have the ABC approach where you resuscitate and simultaneously do the ABCs so that we optimize the patient very soon.
Right, sir. So the possibilities are, as you say, like maybe a cardiac event or sepsis becoming systemic sepsis, or
Yes.
some other embolism. Would you consider embolism in this case?
Unlikely. Because generally pulmonary embolism, amniotic fluid embolism can be there because she has hemorrhage, so we cannot rule out. It has to be one of the differentials because she has desaturated respiratory distress. So we just have to have differential diagnosis and have a diagnostic workup so that we can linchpin the right diagnosis.
So what would you think if that she also had postpartum hemorrhage and immediately minutes after she went into respiratory distress? What could be the cause of peripartum hemorrhage in this case, given that she didn't have any risk factors, no medical comorbidities, she did not into in pregnancy? What could be the possible cause?
See, most of the time when you have underlying postpartum hemorrhage, either it is related to IVF pregnancy, morbidity, obesity, which are the two cause itself per se can cause PPH. But a leakage of water like with PROM, underlying sepsis can be cause of PPH, and coagulopathic issues which can happen because of embolic disorders, amniotic fluid embolism also can cause postpartum hemorrhage. which can induce hemodynamic instability. And this patient, you said she became drowsy. So when the patient becomes drowsy, it could be either again a sepsis caused or hypoxic. Oxygen delivery to the brain is reduced, so they become little groggy, and we need to keep that in mind. So either a cardiogenic shock, a septic shock / embolic shock. So we just have to work on those lines.
Thank you, sir. So next, moving on to how do you manage, like now we have to manage this patient in the operation theatre. Of course, the anesthetist had sedated and ventilated this patient. Dr. Anju ma'am, would you like to throw light on the challenges involved, especially in securing airway in a pregnant patient, and then followed by what kind of fluids are the specific drugs that you would be using in this case? Anju ma'am.
So I think we were doing the case under spinal, if I'm correct. Yeah. And
Yes.
then we have a PPH on our hands, and we are anticipating a long haul with this patient. So we will have to understand that while we decide to intubate this patient and carry it further, we'll keep in mind that the pregnant airway is both anatomically as well as physiologically difficult. And we had a lovely discussion on physiological difficult airway. They desaturate fast, they have low FRCs. And in this case, because there is an element of either cardiogenic or septic shock, she's going to further deteriorate as well as get hypotensive. So, and we are keeping a kind of a differential for cardiogenic shock. So therefore, your fluid boluses will need to be now titrated. And we have to keep in mind that we have an expert for airway management. We have a method to not only pre-oxygenate, but as well as para-oxygenate. That means either a HFNC or a low flow nasal oxygen up there during the time of intubation. The best person on the team at that point in time, the most expert, intubates. But we do a just before we start intubating and we are pre-oxygenating, we do a pre-briefing and just allocate roles to everybody, because that's very important that everybody knows what they are doing and what are our backup in case we have a difficult airway and we are not able to, our rescue devices are there and everything is there. So I would believe a first line of video laryngoscopy in which you are an expert would be the best way to do it if you have access to it. If not, then of course you will have to go with whatever is available to you, and you have an expertise. A second generation LME is a good thing as a kind of a backup device for that is what I'm talking about. Airway management and fluids, of course, we need to optimize this patient's preload, but then we have to be very cautious because on one end we might be thinking septic shock, and the other thing we might be thinking about cardiogenic shock, as well as the patient is bleeding. So I believe in your setup, if you have access to blood and blood products, that should be now activated. An MTP protocol needs to be activated for that. Drugs, of course, we had a nice discussion about drugs. Etomidate is one good way to, titrating. It can be used for induction. And we need to keep an inotrope and a vasopressor online while we are doing the induction and airway management. An arterial line, we should have a low threshold for putting up an arterial line. Of course, widebore IV access, because we're also looking at PPH. So I believe in whole, since a lot of things are hemodynamic management or respiratory management, everything is going in together. We need to emphasize that whoever is there on the floor needs to be allocated roles and clearly briefed on what we are going to do. That's how I think I would like to proceed in this patient.
So I think fluid-wise, we have to give cautious small boluses of crystalloids that we mainly would like to resuscitate a setting, while we are at the same time setting up trigger and making arrangements to collect the blood products. And drug-wise, specific drug, because atonic PPH is one of the commonest causes of PPH. And would you like to start any oxytocin, for uterine contraction at this point of time?
Yeah, definitely. But if we are on the back of our mind, we're thinking about maybe say a cardiogenic cause or PPCM on the back of our minds, we'll have to go in cautiously with the oxytocin, maybe not use boluses, but maybe use infusions, and have our obstetrician to have a low threshold for, uterine compression sutures or, balloon tamponade. All of these things would be much, combined together to look at atonic PPH in these patients.
Dr. Sunil, please, your comments on using
just a word of caution, because a lot of discussion has happened on atomidate in the previous session also. Atomidate is not that cardiovascularly stable. Yes, compared to propofol, it is stable, but in a critically ill patient, be it pregnant patient or non-pregnant patient, when the patient has underlying myocardial depression, which can happen in varied conditions in ICU, atomidate is not that cardiovascularly stable. So you need to be cautious. And I would always go for ketamine in such scenarios, as has been wonderfully elucidated in the earlier discussion. So atomidate is not that stable in a patient who is sick in ICU, especially with underlying myocardial depression.
Yeah, especially when we are suspecting it, especially this patient in this right context, there's a big suspicion of any sudden deteriorations actually points towards a cardiac factor. In this case, especially with the PNC has been, ANC period has been uneventful.
Yeah.
And in terms of vasopressors, actually, I would like to emphasize because in India, in Southeast Asia subcontinent, we are operating many low resource settings. And in those places, actually, in terms of vasopressors, there are some queries in the box also regarding what kind of vasopressors could be used. So ephedrine is a safe drug, and most of the times we are using it in the operating room. And at the same time, I would also like to emphasize about usage of noradrenaline through the peripheral line in the small doses, and do not hesitate to start low doses through the small lines at a less than 0.05 mils per kg per minute. This is safe enough to be started while you buy time to do further corrective measures. So we proceed to the next scenario where the patient now has been intubated, shifted to the ICU. Now, what are the points to focus in management in ICU? Dr. Ranajit, would you like to?
Well, thank you, Dr. Sharmili. Can you hear me properly?
Yes, you're very much audible. Yeah.
All right. Thank you, and thank you so much for this question. Actually, the maternal complications and mortality India is dealing with for the last so many years, and we have done tremendous progress in decreasing the maternal complications to by 86% over the last 20 years, 2 decades. But still, we are still contributing to around 7% of the maternal mortality of the whole world. And in this situation, when you are telling that a patient who has been done a good, that is a checkup, antenatal checkup with no problems, with obesity coming back, you are having a patient relative standing outside to have a good news where you are going to face such a devastating complication. So, such a big stress on us also, that has to be remembered. Now shifted to the ICU. Before shifting to the ICU, that is a very important point, from shifting from OT to the ICU. This part has to be very, very important and careful. Many a times patients deteriorate when you are shifting your patients from the OT to the ICU. You should have a good, proper team who is trained in shifting purposes when you are coming to the ICU. So first of all, that is very important to make your team trained, how to shift your patients from OT to the ICU, how to keep your transport ventilators, how to keep your tube intact, how to keep your lines intact, and then only you shift the patient to the ICU. So once the patient is shifted to the ICU, I start with the basics. First of all, I check my tube, whether it is in the place or not. Once I am satisfied, I see what are the lines my anesthetist friend has put there. If the lines are still not sufficient, I'll back up my team to put it as quickly as possible, because they are having postpartum hemorrhage. I don't know where I'm going to land up it. I set up my ventilator in that way, because thinking that, as Dr. Pandya said, that such acute onset of respiratory distress just following postpartum hemorrhage. So that gives you a concern. Either you have given some fluids, which is called pulmonary edema, or you have landed into pulmonary embolism, or you have gone into a situation you are going towards postpartum cardiomyopathy. Or you also have to rule out, with that severe, if there is hemodynamic compromise, we don't know whether there is a pneumothorax. So we have to rule out all these things. For that, I should have the best thing that can be available with me is my ultrasound probe. By the time I was already asked my residents to put the monitoring, and I have taken a simple sample to send to certain basic tests which can be done inside the ICU itself. Every ICU should have certain tests which should be done inside the ICU. Obviously, all of us are having an arterial blood gas, but apart from that, we should have a SOB test, which includes the shortness of breath test, that includes a D-dimer, a myoglobin, a CPKMB, a troponin I, and a BNP. So this will help me great way in in excluding my patients. So I put my ultrasound, and I also have sent my CBC, and also have done my PT-INR APTT by the bedside because it had to be there in the ICU. So if my APTT is
May I
raised,
interrupt you,
if my
Dr.
INR
Ravijit?
is raised,
Can I interrupt? Would you be specific? What all findings would you look at in POCUS, the point of care ultrasound?
yes, that I'm going into. All right. For the ultrasound, first of all, I should rule out whether there is pulmonary edema or not. That was discussed first. Then I should have a good look at the heart. I should be trained in doing an echocardiography. I'll see whether there is a huge pressure on my left ventricle or not from the right ventricle. And along with that, if my veins are full and the D-dimer is raised, which I've already sent, so it might be a case of pulmonary embolus. Or I'll see the ejection fraction going down below 45%. My fractional shortening below 30% might be a case of peripartum cardiomyopathy. Total number of B lines present in my lung, full of water, may be a case of pulmonary edema. I find a stratosphere sign, it may be a case of pneumothorax. The only problem is that when I'm focusing on the IVC in this situation, when the patient is there, it might be deceiving to me. So in order to see the fluid responsiveness that has been there, I might have to find either a VTI or a carotid VTI. And I do a PLR and I see the change in the cardiac output because IVC might be very detrimental. So I focus on my monitoring very specifically and to diagnose. And by the time I also see the hemorrhagic part that you are talking about, I have to see whether the patient is moving towards DIC or not. And I have to give the fluids and I have to give my blood products because you are now having hemorrhage in that ratio of 1:1:1 that we follow in the ICU. So we have to do that by doing a monitoring, by doing that hemodynamic monitoring, the dynamic parameters, so that I do not overload my patient.
Thank you. So at this end of this resuscitation and ICU management, now relatives, they are from a well-to-do background and they wish to shift to a higher center. So what all, Dr. Kajal, ma'am, what all precautions would you like to follow for transfer of an obstetric patient who is in shock and on ventilator? Because this is a very challenging situation. India being a large country and 80% are in villages, rural health centers, we often get this problem. So what would be the cautions would you follow?
So thank you, Shamili, for this important question. And we must first and foremost make a note of this in our mind, that transfer of a critically ill obstetric patient is a critical event. So when we say critically ill, if I say the blood pressure of the patient is like 60/40 or 50/30, I have to transfer this patient. I should know what are my, what is there in my armamentarium. Most of the times when these patients are shifted from a rural to a higher setup, the patient doesn't have anything to control the bleed. If I think this patient is in shock, I'm understanding that I need to control the bleed. So the very, very, simple way of doing it is using pneumatic anti-shock garments. Now, pneumatic anti-shock garments are freely available in India and they're very easy to apply. They do not require any expertise. They've got multiple small tunicae, which you can start from the ankle down up to the calf, thigh, and then they can be applied on the arms. And they're so individually placed that you can remove them also in case you need them. So first and foremost, my first go-to thing would be that if the patient has to be transferred to any place within the hospital or outside the hospital, patient should be on anti-shock garment, which can save lives of so many bleeding particles. And this can save the life up to 48 hours. You have to just know at what time you have applied because you're occluding the blood flow beyond that point. Number one. And the number two thing which I really want to stress upon is that keep your patient warm. It doesn't require anything much. You can just wrap her in blankets. And the last time when I asked my obstetric colleague to send the patient warm, she warmed up quite a few saline bottles and the patient had burns. So be aware of these kind of, jugaads. You have to have something warm, but it should not be hot. If you keep your patient warm, you save your patient from the lethal triad from which you are trying to, avoid, as these things lead to cardiac arrest on arrival. Extremely acidotic, coagulopathic, hypothermic patients can have a cardiac arrest at any time, which is refractory to your high quality CPRs because nothing works in these patients. So simple maneuvers like anti-shock garments and keeping the patient warm keeping your IV line patent if you are shifting from a hospital, and shifting them on whatever drips you can, like of the vasopressor and saline. Simplest solution.
Thank you. I think very important and practical points you have put forth, and this is very much doable at all levels. And IV lines, I would recommend minimum 2 IV lines, walking lines should be there. So now this patient comes to the higher center. At arrival in the emergency room, patient is on ventilator, BP is on the lower side with some amount of NORAD hooked in, and heart rate is still high, sinus 150, saturation is 100% with FIO to 100%, and NORAD is running through a peripheral line at 5 mils per hour. TLC count report, which is also come with her from outside, is 23,000. And today echo, which was quickly done because we had a telephonic conversation, some handover, so we had the echo ready, which showed us severe LV dysfunctions, that is global hypokinesia, ejection fraction 25%, and dilated LA and LV. And so at this point, more or less, we have, we can narrow it down to peripartum cardiomyopathy, and of course a big suspicion of septic shock also, with a history of leaking waters and TLC of 23,000. Now what will be your plan of management, Dr. Sunil?
Yeah, so basically, again, as we provisionally diagnose this patient as a case of shock, query sepsis, query cardiomyopathy or cardiogenic shock, we need to make sure that we stabilize the hemodynamics appropriately with judicious fluid management, as has been said by Dr. Ranjit, focus guided. Importantly, appropriate dosing of vasopressor, and we need to activate the sepsis bundle so that we can give the right antibiotic or empirical antibody can be started. So our one sepsis bundle, or at least first 3 hours of sepsis bundle, wherein we do an ABG, measure lactates and appropriate cultures. In this case, at least when I say blood culture, 2 sets of aerobic, anaerobic, and as well as we should send urine culture also. And if possible, if the placenta is still intact, we can send the placental coagulatin also for the culture, which has a better yield of microbes. So cultures, lactates and fluids, cautious with fluids, ionopressors. Again, judicious use of noradrenaline, vasopressin if there is a need, because we need to step up the pressures to at least map of around 65 to 70. And because this patient is having SpO2 of 100%, probably based on ABG, we can come down on FiO2 appropriately so that we don't give high FiO2s. So basically,
can I ask you, would you like to give vitamin here, given this kind of hypokinesia and ejection fraction findings?
Yeah, low dose dobutamine can be given to improve the contractility, but again, you need to be cautious because dobutamine is going to further worsen the hypotension. So first thing is start noradrenaline, vasopressin, and then start low dose dobutamine to maintain the or enhance the contractility.
Yeah, I have a little point to differ here, because this patient, though obviously this echo finding dictates right away for initiating dobutamine and kind of inotrope, but with a heart rate of 150 per minute, probably dobutamine is not a good choice at this point. So, we just maintain the map with the perfusion goals with around 65 to 70, ensuring blood acidosis status, lactate, etc. And then we probably wait for heart rate to at least to come down to some state to look for, to consider dobutamine or any other. That is the commonly chosen inotrope. So next now,
dobutamine only once you stabilize, not initially. Initially, it's only noradrenaline and vasopressin, and if necessary, adrenaline.
That's a point to note, because many places, once this global hypokinesia is witnessed, usually cardiologists are in a hurry to advise dobutamine and it just goes on. But I think unless your heart rate is less than 120, do not start dobutamine, because this precipitates life-threatening tachyarrhythmias and shock becomes refractory. Now in the patient is in ICU. Now there has been also a question in the chat box, quite a few repetitive questions on the ventilation goals for such patients. Dr. Ranajit, would you like to talk about the ventilation goals or the proper specific strategies for ventilation for pregnant women who are on mechanical ventilation? And now this patient has also delivered, though still little enlarged uterus.
Yeah. So normally when you are going to face this type of patients, we know that already your ejection fraction, in this patient particularly concern, the ejection fraction already is low, because you are not having a very good around less than 45%. So when you are giving that increased intrathecal secretion, so you are again going to decrease the preload further. So sometimes it might be beneficial for the patient when you're giving a ventilation. The right side of the heart, the preload is decreased. The left side, the afterload is decreased. Sometimes it might be beneficial. So normally we follow a low tidal volume ventilation around 6 ml per kg body weight. We try to make adequate oxygenation with the help of PEEP. When I select PEEP, we basically try, what we do in our ICU, we try to see the static compliance of the patient. The best static compliance and the driving pressure, we try to keep it below 40. And the static compliance, which is based at a particular PEEP. For example, I go on increasing my PEEP from 4 to 5 to 6 to 7. I see my static compliance increasing. The best one where the static compliance I get, I fix my PEEP there. And remember that here, if I'm going to give a lot of positive expiratory pressure, that might be detrimental to the patient. I cannot exactly tell you what typical ventilatory measure, that is the settings that I can give here. It changes according to the patient's situation, But low tidal volume ventilation and PEEP measurements can be given like this. That's what I can tell about this one.
So this patient probably with a high now with the demonstrated low ejection fraction and hypokinesia, little bit of higher PEEP would actually benefit these patients. Of course, you'd be backed it with imaging, ultrasound or chest X-ray later on. Yes. We have already covered this vasopressin and POCUS. What antibiotics would you choose, Dr. Rajit?
Well, first of all, I want to speak about a bit of the ionotropes here. So this is the most difficult situation for an intensivist when you face a patient of peripartum cardiomyopathy along with sepsis. On one hand, you want to increase the cardiac pump. On the other hand, the moment you are giving a dobutamine, you are getting some amount of vasodilatation, and that is going to decrease your cardiac function. So here, the most important thing that has to be done is a meticulous monitoring. Now, how to monitor my patients? The moment I start talking about the elite monitoring system that most of us speak about, like the pulse pressure variation, the stroke volume variation, most of us do not have this monitoring with us. We have to remember that. And most of the times with a low tidal volume ventilation, with a cardiac failure situation, these monitors are ineffective. So a simple monitoring but effective monitoring, maybe with the help of my ultrasound, and also with the passive leg raising test, we can do that. What we want to achieve, as Dr. Pandya said, it's very important to achieve that mean arterial pressure of 65 with my vasopressors. Then I see I have to increase my hemoglobin level because I have to carry the oxygen to the tissues. And if I see that by the delta CO2 gap, if I do not know how to see the cardiac output with the help of my ultrasound, if it is increasing more than 6, 7, this is the time I have to start dobutamine. And if I start dobutamine earlier than this, it may be very detrimental. So dobutamine has to be started with a lot of caution, with a lot of monitoring. Regarding antibiotics...
Sorry for interrupting you. What antibiotics would you choose in this case?
Yes, I'm going to, regarding the antibiotics, I'll start with a broad spectrum antibiotic. My ICU should have its own antibiotic protocol according to my own antibiogram that every ICU should develop that. I'll start with the broad spectrum, maybe a third generation cephalosporin. I give a coverage, the anaerobic coverage, metronidazole. I might have to add some amount of ampicillin or salbactam along with that in the later time when the patient is not improving from the symptoms.
Yeah,
Very
so
short.
That's a good coverage with broad spectrum antibiotic and some anaerobic coverage for this kind of patients. Now, subsequently, she was gradually weaned off ventilation. She was extubated on day 4 and shifted to ward on day 6. All cultures which were sent initially on admission to ER came negative. So, what are the risk factors for developing peripartum cardiomyopathy? Dr. Anjuman.
So I believe, as in this case, we have an obese patient. We have a patient who has undergone for assisted reproductive, IVF treatment. She has undergone that. Apart from that, advanced age, multiparity, and of course, there have been a thought about African descent of parturients because there has been a linkage found to be having some kind of a genetic predisposition to that. But having said that, it's very important that we also look at hypertensive disorders of pregnancy and preeclampsia because these are the kind of women that might also present in the similar fashion or may have concomitant systolic and diastolic dysfunctions going together. So these are kind of things that we really need to be on a lookout for these in these pregnant women. I believe I've kind of touched all of them.
Right, right. So coming to Dr. Kajal ma'am, could this have been prevented, and what are the chances of recovery and risk of recurrence in subsequent pregnancies?
Well, I don't know if it can be prevented, but it can be predicted, definitely. And the recovery patterns, these normally PPCMs, they happen when the ejection fractions, they drop below 45. So what we consider is if these women, they recover 50 to 55, that is a recovery which is typically expected to happen in 6 months to 1 year, depending upon the region and how Anju has just stated, depending upon the ethnicity and the race. So roughly from one article, it is quoted that 21 to 63% of the women, they recover within 6 months with a visual ejection fraction of 50 to 55%. Well, if these women, they recover with a more than 55 in a year, they should be given a rider that the subsequent pregnancy should happen under the care of a cardiologist and under the supervision of a multidisciplinary team, because there may be a risk of recurrence. These women are also typically continued on their heart failure medications like their ARBs and their beta blockers and AC inhibitors. And this is also to prevent the subsequent recurrence in the pregnancy, in the subsequent pregnancy. So all said and done, women who do not recover should not be, conceiving without prior consultation, because they're at high risk of morbidity and mortality. Those who recover beyond 55 after 1 year of pregnancy should be in a higher center. So I hope I have answered that question in a crisp way.
Yeah, thank you. I think very important points you have made, and this is all things that need to be kept in mind, and patient's family, both the husband and wife, should be counseled about it, because there are subsequent enormous implications. So in that regard, I would actually also going to ask Dr. Sunil, and he has raised the hand also. So your comments, and do you believe that every patient who are in the little higher categories or in the precious bracket, or those who can afford, should today echo be advised in such cases as well? Because this patient did not have an echo. Dr. Sunil, please.
In fact, in this patient, obesity and IVF itself is an indication that they should have a based on ECG as well as an echo, which is sort of a protocol in our hospital. So I was just coming to the earlier question about recurrence. See, when the patient has an ejection fraction of less than 25%, the initial presentation, the recurrence risk is almost close to 45% in subsequent pregnancy. This has to be told to the patient, even if they recover completely in the current pregnancy. There is one thing. Second important thing is we always have to look at the left ventricular end-diastolic diameter once the patient has been stabilized, when the EF improves. So if the left ventricular end-diastolic diameter is still more than 4.8 centimeters to 5.2 centimeters, again the risk of recurrence is quite high. So probably we just have to have echocardiographic follow-up as well as the biomarker NT-proBNP follow-up also on the long-term basis, and subsequent pregnancies we just have to have, as Dr. Kajal said rightly, a multidisciplinary approach to assess whether she can have a safe pregnancy, but definitely risk of recurrence is quite high. And bromocriptine antagonist also is one of the things that has been mentioned in the management once the patient stabilizes, because they are known to enhance the recovery. The only thing is, yes, they have to stop breastfeeding, and then the babies have to be on the bottle feeds. But bromocriptine also is known to enhance the recovery from severe LV dysfunction.
So there are, thank you, sir, for these valuable points. And there are many questions in the chat box regarding this obstetric case. And one of the questions quickly I would ask Dr. Kajal ma'am, what will be your choices of sedation and analgesia when the patient has been on mechanical ventilation for these patients? I see many colleagues joining us from Indonesia, and there are more than already 15 questions on this.
See, there are no magic bullet these days. Whatever the sedation we do, it is as per the patient's profile. For example, if this patient comes to me in shock, then obviously when I use propofol, I know I have to go very low on that. If I use dexmedetomidine, then I have to again be very mindful of the hypotension with the increased doses. So everything has to be titrated to effect. Like if you use propofol with dexmedetomidine or fentanyl, you have to titrate based on the sedation level you are targeting and the patient, how much the patient is going to tolerate. But the drugs remain the same. Fentanyl, propofol or dexmedetomidine.
Right. Thank you, ma'am. So coming to another broad entity in these patients with very specific categories, sepsis in obstetric patients. Dr. Ranaji, do you think it's a distinct entity compared to the septic shock? I mean, I would say the severe form of it, septic shock. Is it a distinct entity and should be managed differently compared to non-pregnant populations? What's your views on this?
Yes, definitely. It's a very thought-provoking question that you asked, and I have thought over maybe for my whole career that it should be a different entity. Just before going to this point, I just want to add one point before you allow me. When you're getting a case of pericardial cardiomyopathy, many times these patients develop pulmonary edema. And when you are developing pulmonary edema, your blood pressure is low. You have to take this fluid out. You are in a very much fix. How exactly you take this fluid out. So you have to depend on ventilation. You have to give adequate amount of PEEP. You have to start with noradrenaline. You have to believe that your diuretics will start working when your blood pressure comes up. And by that time, it doesn't happen. The patient might succumb. We have used successfully in our center slow continuous ultrafiltration in these type of patients. And believe me, if you're removing that fluid slowly from the patient, only a bit of ultrafiltration, these patients survive and these patients improve drastically. We have a series of cases, one of them has already been published, so I thought I should share it.
Yes.
And regarding...
please continue.
Yes, please.
So should the diagnostic criteria be different when you define septic shock in general population?
Yes,
given the physiological changes of vasodilation,
I'm going to that. I'm coming to that point now. Yes, definitely it is unique, because in pregnancy, you are having vasodilatation, you are having increased blood volume by around 30%. The heart rate is increased, the respiratory rate is increased. Also, altered immune response is there, leading to infections. The quality and the type of infection is completely different from that of the normal population. You have fetal implications. Everything is different here in a pregnant patient. So, the societies are coming out with certain definitions, certain changes. For example, they're changing in the Q SOFA. They're increasing the respiratory rate to 25. They're decreasing the blood pressure to 90 rather than 100. So they're coming up, they're trying to do that because we have to think that these are unique kind of patients. And the sepsis, the component of sepsis is masked due to all this type of additional physiological changes that are occurring in the patient. So the sepsis is masked. So we'll be very, very meticulous about it. So that is the reason why the entity should be different. Similarly, a gross giving fluid of around 30 ml per kg body weight, I don't think can be applied here in this type of patients. Maybe as you are telling, you have to give in small aliquots and you have to just monitor whether this patient is going into failure or not, into fluid overload or not. So we have to think about all these things.
Thank you, Dr. Ranajit. And quickly we'll take up a couple of questions and then we'll have to wind up. A question about a patient who is having a third grade placenta accreta. What kind of anesthesia would you propose, or Dr. Sunil or Dr. Kajal?
As a protocol in our hospital, we always start off with regional anesthesia in even placenta percreta or accreta cases, with a backup of GA if the patient has major hemorrhage. And basically, these are the patients where it's a multidisciplinary team decision, and we are all ready with a backup plan of plan A and plan B and plan C. So we start off with regional anesthesia, always establish maternal bonding, and subsequently, I would say 90% of the cases they continue to be in the regional. I would say more than 95%. 5% they require conversion to general anesthesia because of major hemorrhage. But by and large, regional anesthesia is the technique of choice.
So Sharmili, I agree with Dr. Sunil, and here I must also say that he has laid a lot of emphasis on the expertise of the operating team. So it is all related to blood and blood management. If the team is not very well equipped with the knowledge of how to do accretas, then it would be fruitful to go ahead with general anesthetics. But if the team is very good, say you have a surgeon who knows how to take control of the iliac, internal iliacs, and they know how to do a fast peripartum hysterectomy, if that is on the cards, then one can go ahead with regionals. Anybody who can manage blood and blood conservation strategies.
Yeah, I think there is one more question on extubation of an obstetric patient who is having pulmonary edema, as our case had, that asking about what would be the safest way to extubate this patient as when they meet the extubation criteria. So I would say you can just think of extubating them onto an IV. So continue some intermittent positive pressure while you're considering extubating on such patients. I see there are not many questions in the chat box, but there is shortage of time. And we have our president, Dr. Srinivas, joined us. I think he was traveling and he's just managed to join. So what would be your key points or take-home points for the audience here? We had actually discussed a patient who had peripartum cardiomyopathy, who also at tinge of sepsis, went into septic shock and needed to be stabilized.
So I was there right through the discussion. So sepsis in obstetric patients is sometimes a little tricky situation to handle because the intrinsic vasodilatation associated with the pregnant state sometimes masks the early manifestations. Said not all
I think you have
access to invasive hemodynamic monitoring, but a sorry?
Your voice was breaking. Now it's okay. Please continue.
Can you hear me?
Yes, yes.
It's breaking.
Am I audible? Okay.
Now it's better, sir.
Better. Please continue.
Okay. So the plethysmographic has to become more standard practice. The choice of antibiotics. Also, we need to look at the specific indications, situations like chorioamnionitis and specific obstetric complications before we choose the antibiotics. The other issue which makes a difference to the dosing of antibiotics in these patients is the volume of distribution, which changes drastically postpartum, and then you need to adjust your drug dosing. The use of NIV has to be done with caution in these patients because the upper airway is relaxed. The protective reflexes are also relaxed, and this is a unique situation where physiological and anatomical difficult airways happen at the same time in the same patient. So there's a little bit of differences in the obstetric patient with sepsis.
Yeah, though not part of this particular case, there has been 2 questions on mechanical ventilation for pregnant patients who is facing ARDS. Not this particular case. Would you like to quickly tell a few points of for these patients, pregnant women landing up in ARDS?
So if the patient has not yet delivered, then you know that the acceptable PCO2 for these patients is between 32 to 35. So if somebody has a CO2 of more than 35, that means they are retaining carbon dioxide. So that is one target. The second thing we need to remember is that the routinely used parameters like driving pressure and plateau pressure the standard definitions do not apply in the pregnant state with a gravid uterus. Because not only in an ARDS setting, because not only is the intrathoracic and the intrapulmonary compliance abnormal, the thoracic and the extrathoracic compliance and the pressure of the gravid uterus also contribute to the driving pressures and the plateau pressures in these patients. So we need to make that adjustment while saying that we have crossed the limit because nowadays we are using driving pressure more to decide which patient goes on to ECMO. So if you are using 13 or 14 or the cutoff of driving pressure for thinking about ECMO in ARDS, we need to go up to about 16 or 17 in the pregnant state. You need to keep the other aspect is permissive hypoxemia is not an entity to be followed in a pregnant state before the delivery of the baby. Normally, we say that a saturation of above 85 or a PaO2 above 60 is good enough for ARDS, but that targets have again to be readjusted upwards to a PaO2 of 80 and a saturation of 90 and above in a pregnant state. You have to take these aspects into consideration.
Thank you for those valid points. Very important because ARDS ventilation in non-pregnant population is very different from a lady who is pregnant, and we had counted so many patients during the COVID pandemic, and we had published PRECOPE study which was a retrospective analysis of pregnant women who were affected with COVID-19 infections. 207 patients we published in ISCCM last year. So last questions, what I see is again from Indonesia. What inotrope to consider in septic encephalopathy? I do not think it has any particular relation in the choosing of inotrope for these cases. Dobutamine, as you said, once the heart rate is less than 120 would be at all a safer agent to use. But if it is more than 120, certainly stay away from using it. And all our goals should be perfusion pressure, including the urine output and from head to toe, looking at the cerebral perfusion pressure, lactate clearance, acidosis, etc. With that, I would like to thank all my panelists, and I'm extremely thankful to the ISCCM leadership for this joint collaborative sessions with ISA and the ICA leadership as well. Thank you, Dr. Mona Lisa, as well.
Thank you, ma'am, for this great session. I would request our President, Dr. Srinivas Samvedam sir, to give the vote of thanks for this and conclude this webinar.
Thank you, Mona, for giving me this opportunity. I thank the ISA for actually obliging us, Dr. Bala Venkat and Dr. Satya Bajwa sir, for actually considering our proposal for doing this joint webinar, and all the panelists for the earlier session and this one for sharing their wisdom and thought process on important topics related to synergistic fields where critical care and anesthesia meet. Critical care, we all know, is a melting pot of all specialties, and anesthesia and critical care actually share a lot of commonalities, not only in the method, in the diseases we treat, but also in the organization. These are the two specialties which are well aware of every single aspect and every single part of the hospital, and these are the two departments tailor-made for leadership. So, once again, on behalf of the ISCCM, we look forward to more such engaging and enlightening discussions with the ISA, and we will also probably include the ISA along with synergistic discussion with other specialties like surgery and orthopedics and neurosurgeons. Thank you all for joining us, and we hope to have more sessions in the future.
Thank you so much, sir. Thank you to all our esteemed speakers, moderators, and our audience also. Hope to see such future academic collaborations.
Dr. Mona Lisa, can I just take a quick minute?
Yes, ma'am.
Yeah, I would take this opportunity to invite all the delegates and the participants here for this obstetric critical workshop, which are going to be conducted, our annual signature event at Critical Care 2026 at Chennai. And also ICCM has rolled out this fantastic course of obstetric critical care fellowship, which is an online course for 6 months, followed by a contact session, and that is an exact exam. So feel free to join and contact us for any queries. Over to you.
Thank you, ma'am. So we'll see you next month, same time, same place in the ISCCM webinar. And we'll be having this ISCCM collaborative webinar every quarterly. So looking forward to future academic collaborations. Thank you. Thank you, everyone.
Thank you.
Thank you, everyone. Thank you. Good night.